So here we go, vasopressors. I'm a physiologist, first of all. I'm not a clinician, so I say things from a different perspective maybe, and I'm interested in mechanisms. So maybe you give your drugs for certain reasons that are different than what I would think you would do, and that's going to be a bit the background of my talk. I have a bunch of declared interests. I won't go through this. But I'm a physiologist. I'm not a clinical doctor, so my job here is to rattle the cage, if you like, and maybe to show to you that vasopressors are really, maybe not such a good drug after all. So over the last year, we've started to come to the realization of a concept we're trying to introduce called hemodynamic coherence. And I think it's the basis of your resuscitation idea. It's going to appear in critical care, and what it basically says is this. What you do is you have parameters at the bedside, like blood pressure and cardiac output, and you give a drug to make a change because you perceive that that is an abnormal value. But what you then assume is that if you change the cardiac output, increase it, or change the blood pressure, that has a beneficial effect in the rest of the body, which you don't know because it's one big black box. So under normal physiology, this occurs if you all of a sudden get a massive bleed and you give that back again, and you don't wait too long, like about 15 minutes is about the maximum, then the vascular regulatory processes which are there are still intact, and the oxygen supply dependency in the different organs and within the different parts of the organs will ensure that every part gets what it needs. However, if that process takes too long and you get reperfusion injury or sepsis or any type of infectious agent, these normal regulatory processes don't work anymore. So you can increase the cardiac output until you're blue in the face, but it won't promote tissue oxygenation per se. So if there is a loss of hemodynamic coherence between the macrocirculation and the microcirculation, this is your non-responsive patient. It means you don't really know what's going on. And you say, oh, the patient's still hypovolemic. You give it another liter of fluid. Still no urine, let's give some Lasix. The blood pressure is very low, so let's increase the blood pressure by constricting the vessels. That sounds like a good idea. So the idea of a loss of hemodynamic coherence, in my opinion, is the issue which leads to an inappropriate administration of fluids and drugs potentially causing harm. So there are 4 essential conditions where there is a loss of hemodynamic coherence. The first one is heterogeneity. It occurs in sepsis, in malaria, in sickle cell anemia. It's really where you have endothelial cell dysfunction, where red blood cells are stiff and sticky, and you get a heterogeneous flow. There are areas that are flowing, there are areas that are not flowing, and we've seen many images that show this. It explains the condition that you have a loss of oxygen extraction. It is basically heterogeneous flow and functional shunting. So to fix this problem, you don't need fluids and vasopressors and stuff like that. You have to correct heterogeneity, which is an endothelial and inflammatory issue. Type 2 is hemodilution. You have given too much fluids, and you have diluted the oxygen carrying capacity of the blood. And what happens that even though there's a lot of flow going in the microcirculation, there's actually a lot of empty vessels. And you have large diffusion distances, also something that you don't see because your resuscitation procedures is completely based on the idea that convection is the problem that needs to be fixed, and not the diffusion distance between the red blood cells and tissue cells. So hemodilution is number 2. Type 3 is what we're going to be talking about today. You've done crazy things with the systemic hemodynamic variables, like giving a lot of vasopressors. It's the patient that has got a lot of noradrenaline, and when you feel the patient, he's cold. So that is a patient that has got maybe a very nice blood pressure, but the tissues are feeling very, very unwell. Or you follow the surviving sepsis guidelines, and you decide to chase the venous pressures above 12 millimeters of mercury, which from our point of view is also not a very smart thing to do because you cause a tamponade, especially in the kidney, which you don't see, but it happens. And type 4 is edema. Of course, if you have a leaky vasculature and you just give fluids chasing hypovolemia, you will just make sure that your organs are getting wetter and wetter. And in my opinion, it's what happened in the FEAST trial. in Kate Maitland's issue. So, of course, in sepsis, probably all four of these are happening at the same time, but you can also imagine that each of these type of alterations will result in a different intervention. Here, maybe anti-inflammatory. Here, maybe a blood transfusion or less fluids. Here, toning down the noradrenaline. And how to fix the vascular leak is still an enigma. So this is what a septic microcirculation looks like. And here you can see the hemodynamic problem that needs to be fixed. It's not that there is insufficient flow, it's just that there are areas which there are flow and there are areas that are not flow. And then you can understand what oxygen extraction deficit is. It's none of this fancy-pantsy stuff about mitochondria, it's simply shunting. And in order to correct this, you're going to need completely different things than just vasopressors and fluids. And if you give a lot of fluids, what happens? It turns into something like this. It goes very, very fast, maybe so fast that the oxygen doesn't have time to offload, and you still have areas which are not being recruited. So this is Christian Bourma, and we wrote a paper actually on, if you look at it from a microcircuitry and a tissue point of view, what vasoactive compounds do. And there are two important things to realize. One is simply Ohm's law, that if you squeeze the vessels, you will get a raise in the arterial pressure here, if it's an arterial vasoconstrictor that you're using, and it will go, and the microcirculation, the pressure at the entrance of the microcirculation will go down. So even though you've got a high pressure, the entrance pressure at the microcirculation will be very low, and there will be a very, very low driving pressure, which is the difference between the entrance and the exit pressure of the microcirculation. Contrast, if you actually open up the microcirculation and vasodilate it, of course saying that you've got enough volume, then what you do is, if the arterial compartment, then the wave, the pressure wave, goes towards the microcirculation and you will get a promotion of flow there. So if it's flow that you're interested in, a vasodilator is a lot more effective than a vasopressor. However, it definitely is true, and there's evidence, and this is one such paper by Jean-Louis Thibault that shows that if you chase pressure, that you're able, in some of the patients, to improve tissue, in this case, tissue oxygenation. However, this landmark paper, which appeared in 2000 by Eric Rakoff and co-workers, David Ledoux, was really the first one that showed that just increasing pressure is not a good. Now, in these days, pressure-guided resuscitation was all the thing. So people were really using a lot of noradrenaline in the hope of improving DO2 and shifting the VO2-DO2 curve. That was the big thing in those days. And he showed for the first time that that really was not very effective. So what he did was he gave increasing doses of noradrenaline, and as you can see here, increasing the blood pressure, heart rate was more or less normal. Indeed, the blood pressure went up as you gave more of this stuff, very, very statistically significant. But if you looked at the DO2, it also increased somewhat, but lactate really had no effect. Downstream parameters were not affected, venous saturation, etc. However, if you looked at the parameters related to tissue perfusion, you saw that they went the complete opposite way. Capillary blood flow measured with laser Doppler went actually down very significantly. No effect on urine output. Here you have red blood cell velocity not having very much impact. So velocity wasn't really improving, but flow, the bulk transport of red blood cells, was going down. That's an important distinction to be made. And really no effect of anything. So even though these blood pressures were being increased substantially, there was no benefit to the tissues. And in the meantime, many, many studies have shown that the more vasopressors that you use to chase the mean arterial pressure, the higher the probability that your patients will die. This is a very nice diagram done by Yuko Takla and his group showing that. And here he has really the mean arterial pressure, and here on this axis the vasopressor load. And you see that the more vasopressors you give to make the mean arterial pressure higher, the mortality increases. And then, of course, you have the complication when you're dealing with vasopressors, at least from a pressor point of view, is the large number of different drugs that are being used, and the large number of heterogeneity of the receptors in the body, and also the way they change depending on the hemodynamic conditions and the pH, for example, about the effectivity of these different drugs. And epinephrine, for example, in the treatment of cardiac arrest, Max Harry Weil, may he rest in peace, was a great adversary against epinephrine, and he showed many studies that using epinephrine in cardiac arrest was really a bad thing. This is one such study looking at microcirculatory flow, and he used this in an animal with precordial compression, showing that if you use actually epinephrine, the flow underneath the tongue really came back down to zero. After he released it, it went back up again, and you saw that with no epinephrine, there was a lot more flow going than with epinephrine. And this also occurred in the brain, that if you had using epinephrine, and vasopressin was in this context a lot more effective. Here you see after the CPR that the flow in the vasopressin group was a lot better than epinephrine, completely no flow at all. So this is a case study which really shows very dramatically how you may be fixing one problem and creating another problem. So this is a case study by Christian Burma, which appeared in Acta Scandinavia, which we did, Okay, let me just see, there we go. And measuring underneath the tongue, it's not a very good picture, but you can clearly see there's flow in this picture, can't you? It's visible. But this patient was an 80-year-old lady who had a meningococcal septic shock. And she had mean arterial pressures around 55, and the clinicians were uncomfortable. She was oliguric. They were afraid of the perfusion of the brain and decided to give a milligram bolus of terlipressin, which is a pretty hefty dose, I think, but nevertheless. The mean arterial pressure increased indeed from 58 to 80, even to 100. Urine output was restored. Fantastic. However, if you looked at the microcirculation, it had ground to a complete and total halt. The patient turned very cold, and a couple of hours later, the patient died with a good mean arterial pressure producing urine. So abnormal microcirculation is really a very important indication that something bad is going on, and this study showed that in 500 patients. Jean-Louis and Daniel de Backer, that of all the hemodynamic parameters, if the microcirculation, like I showed you, remained like that, it was the single most sensitive predictor of an adverse outcome. So we did an international study with Arnaldo Dubin from Argentina, Glenn Hernandez, and Christian Burma, and we asked the question, if you look at the microcirculation and you see alterations in there, what are the clinical parameters associated with this phenotype? Because we know it's got a very bad prognosis. It had nothing to do with cardiac index or SVO2. These were patients, there was no hemodynamic coherence between the macro and the microcirculation, no relationship at all between bad microcirculation and SVO2 or cardiac index. However, the lactate was very significantly correlated, and the load of noradrenaline. So the vasopressor load was directly related to abnormal microcirculation. Now, whether one was causing the other, that's of course something that we could not distinguish in this particular study. So can you increase the blood pressure and expect an improvement in the microcirculation? Because I can't think of any other reason for giving a vasopressor if that's not happening. This is a study by Rupert Pierce and Shamin Janjay in postoperative septic shock patients, and they really show that even though they were very successful in increasing mean arterial pressure, there was absolutely no effect on flow, and there was a slight increase in flux, that's velocity, once they'd gotten on to mean arterial pressures of 90. And then Arnaldo Dubin, at the same time, did the same study, and he also showed that there really was no improvement in the velocity or the flux, but he did find, very interestingly, that if you looked at low blood pressure, there were, and you looked at the percentage of perfused vessels, which is basically the functional capillary density, a measure of the diffusion distance between the cells. So the closer that the diffusion is, the better that it is for oxygen transport. That there were patients who had low, but there were also patients who had high capillary densities. And it was only the low ones that benefited from norepinephrine treatment. And if you already had a normal flux or a high, the opposite happened. You actually got an adverse outcome. So it's all about flow. It has nothing to do with mean arterial pressure. So if that's true, what's the story about vasodilators? Maybe we should abandon it completely. So from a hemodynamic point of view, it is much better to open up the circulation than to close it, just from a simple Ohm's law perspective. And here's a patient by Peter Sprong, very nicely showing this. So this patient has a central line. I'm almost finished, sirs. And you can see here, that depending on the placement of central line, on the right hand, a drip is induced with nitroglycerin. And you can see the color change in the right hand with respect to the left hand. See, it's more red than, and it's still blue. So opening up the venous. So it's very, very, vasodilation is better for the tissue perfusion. And together with Dirk Sonstra, we showed in the days where people were using a lot of vasopressors, pressure-guided resuscitation was the thing to do, that if you gave nitroglycerin, you were able to open up the microcirculation, whereas pressure-guided patients had almost stasis in their microcirculation, giving a nitroglycerin drip opened up, and it was at that time a very, very controversial idea. We then did a randomized placebo-controlled trial in which we gave a single dose of nitroglycerin, and even though as the patients were being treated, the microcirculatory flow index improved, there was no difference between nitroglycerin and the placebo. And in Holland, nitroglycerin was a big thing. Everybody uses it. I think it's probably the only country that does so. But not only that, so maybe you should have given more. So Alex Lima, he titrated nitroglycerin, and you could titrate nitroglycerin very nicely, and all your peripheral perfusion indices you can improve, whether it be PFI or capillary refill time or near-infrared spectroscopy. When you stop the nitroglycerin, it goes back to baseline. So you can recruit the microcirculation. However, even though in our study there was an improvement in the peripheral temperature, so we were opening up the peripheral tissue with a single dose, we found an increase in mortality in the nitroglycerin group. So nitroglycerin is not an innocent compound. As people in cardiology know, nitrite tolerance is an issue, etc. Why this happened, we don't know, but it definitely was there. So the last two slides, you can also, of course, decrease afterload. So instead of the front, you can look at the back and reduce the venous pressure. So this is an example of that. This is a patient with heart failure. And you can very clearly see the very, very slow flow that a heart failure patient has. It's a typical phenotype. You can almost identify blinded that a patient has got heart failure based on these very, very slow. So if you give this patient an oxybone, which is a phosphodiesterase inhibitor, the patient looks like this. And then you can see that the flow is much better. So probably vasodilators in the presence of sufficient amounts of flow is a lot better. And I would definitely agree with this viewpoint paper, rethinking resuscitation, leaving blood pressure cosmetics behind, and moving forwards to permissive hypotension and a tissue perfusion-based approach. It could have been the title of this talk. So I would say go with the flow. Thank you very much.